So the biggest challenge is that the lung is insensate. That is, that you can't feel when there's a cancer that's growing inside your lung. So if you wait until symptoms develop, which is typically shortness of breath or coughing up blood, the cancer is quite large. We've had quite a bit of success around the world now instituting lung cancer screening. So really for the first time, we're beginning to see some increase in the number of stage 1 cancers. It used to be about 15%. It's now up to about 19% of the people who are coming in with earlier stage 1 cancers. This then in turn allows us to offer lung sparing operations. So you no longer have to do pneumonectomies. You may not have to do lobectomies. For certain selected patients, we're doing more segmentectomies. A segment is a further subdivision of a lobe. So instead of coming in and having a right pneumonectomy, which would take 60% of your lung cancer, you could have a segment and lose 5% of the lung tissue, rather, not a lung cancer. But if you only lose 5%, then your recovery time is much faster. It can be done more reliably with very minimally invasive techniques and small incisions. And then that expands also who in turn can receive the therapy. Yeah, I think there are several aspects to geriatric patients that lung cancer surgery underscores or unveils. Frequently, we hear the stories of patients who have been very robust, walking through snowstorms to go to the grocery store, but now faced with potential surgery and a careful interview, you begin to find out, well, they were hospitalized last January for pneumonia, and they're really not going out of the house anymore since that hospitalization. And there is a visiting nurse who's coming to see them twice a week because they need assistance with their activities of daily living. Those patients can be treated very successfully with modern techniques for lung cancer surgery, with minimally invasive techniques, lung-sparing operations. So the pool at which the people that would benefit the most has greatly expanded. Yeah, I think the biggest area of advance is with the screening. We're seeing earlier cancers, smaller cancers. There's a dramatic shift in my field towards lung-sparing operations, more segments, quicker recovery times, getting people not to rehab facilities, but back to their own home environment within a week of the surgery with these really smaller types of operations. So that's all on the good side. The challenges that remain is smoking cessation. The lung cancer screening programs have required that you at least approach the subject of smoking cessation with our patients. And it really is a golden opportunity, because if you can get them to quit smoking before a planned operation as part of a whole prehabilitation plan, that then sets you up for success in the immediate postoperative period. And like any other addiction, there may be restarting of that type of behavior, but if you keep working at it in the follow-up period when you're seeing if there are any signs of recurrence of cancer, there's a tremendous potential for success. But I think it's not necessarily linked in people's mind with the surgery the way it should be. I think that a plan for smoking cessation prior to surgery makes sense, prior to any therapy makes sense. I think any type of plan where you ask your patient to sort of pay attention to how many steps that you take a day, or what is the nutrition that you're taking in, or what's the sleep habits that you're having, sets you up for a more successful recovery from surgery or from any type of therapy. Yeah, so tomorrow is actually quite interesting. It's looking at surgery as part of a multidisciplinary approach to people with what's called regionally advanced cancer or systemic cancer. So it's stage 3 and stage 4. Most people think of surgery in terms of stage 1 and 2, and certainly, hands down, surgery has the best overall survival if you apply it to stage 1 and stage 2. When you get to stage 3 and stage 4, surgery cannot handle that problem completely by its own, but neither can chemotherapy or radiation. And so it becomes the skilled application of multiple modalities that gives you the best chance of success. So that requires really close communication between the medical oncologist, the geriatrician, the radiation oncologist, and the surgeon to discuss what's going to be treated, what are the fields, what are the doses, but most importantly, what's the timing? Which modality will come first? Will there be a rest period before the next modality? How do you balance use of prednisone for brain mets, for instance? So all these require quite a bit of collegiality and collaboration. And that's why I think we see the big success in what we call multidisciplinary clinics. Those are clinics where you have people of different specialties in the same clinic seeing the same patient at the same time. Plus, it gives them choices. So you don't have to hear from a surgeon, you know, if you were to ask, well, do I have to have surgery? Couldn't I have radiation? You're not hearing the surgeon tell you about the pros and cons of radiation. You would hear that from the radiation oncologist. We do believe that everybody's entitled to an accurate diagnosis, which requires tissue sampling, an accurate stage, and then a joint team that comes together and talks about what's the recommendation for the best treatment for the patient. Then with the elderly patient, you have to be open as a surgeon that they may choose no treatment, they may choose partial treatment, or they may choose full treatment. And if they choose full treatment, they may change their mind as they start to get some of the unwanted side effects, for instance. So our goal is to minimize those side effects, minimize the time of impairment, and offer the best oncologic operation. The more that we find these lesions when they're smaller, the more success we'll have in that project. I would say that there's a lot of nihilism when it comes to lung cancer. People view it still as a death sentence, and it's not that way, that there are advances in techniques on all aspects of care, and it can be an opportunity to sort of take an isolated elderly patient who's now living by themselves, improve their social network, improve their overall health, treat the cancer, but then also have them in a better health state 1 year later than they were 1 year before.